So good evening, everyone. Thank you so much for joining us for this webinar discussing the nitty-gritty of perioperative TORS management. I'm Eleni Reddig. I'm a head and neck surgeon at Brigham and Women's and Dana-Farber in Boston, and my co-host is Michelle Chen, who's a head and neck surgeon at Stanford. And I will introduce our panelists shortly. The objectives of our webinar is to share practices and experiences regarding perioperative decision-making for TORS, and we will include brief discussions of an evidence base where it's available, but mostly we want this to be a discussion of kind of tips and tricks and really getting into the nuts and bolts of what we do during TORS. And our panelists are Ryan Lee from OHSU, Ryan Jackson from WashU, Ann Kane from University of Mississippi, and Alex Kegner from MUSC. And I'm very excited to hear what they have to say. We have a great group of experienced and a lot of wisdom here. Okay. We do have some disclosures, which are shown here. And one final disclosure is that a lot of what we're going to talk about is kind of, what everyone does or what kind of the common practices are. But just to remind everyone that you don't have to do what everyone else is doing, but sometimes they do have a good point. So take everything kind of with a grain of salt here. All right, we'll dive right in. This is going to be a bit of a mix of some case-based discussions, some survey questions, and brief presentations. So we'll start with kind of your standard TORS case. We have a 45-year-old male, healthy, never smoker with a cute little T1N0 HPV 16 positive squam of the right tonsil. It's a 1 centimeter mobile exophytic tumor, and he's a Mallampati 1, excellent TORS candidate. So just to start with some very basic questions, we will target these ones towards Dr. Kegner. So what is your intubation preference? Which retractor do you use, and which robot do you use?
So usually I do an oral intubation. I actually don't always have to use a reinforced tube, but regular tube sometimes works just fine. With retractors, I have a love affair with the MacGyver. So I like the MacGyver. It's great for even if they don't have any teeth. I don't put a tongue stitch in. Sometimes I will use the FK with the the WO retractor as well. We only have one robot, so for us at least. So I use the SP, and yeah.
Okay. What if we change this up a little bit to a tongue-based tumor, similar T1 mobile, cute little exophytic thing? Would you change your intubation or your retractor use?
I would definitely use the FKWO for the tongue base. I was using the MacGyver, but it was causing a little more tongue edema. And so I switched back over to using the FK. But you can get really nice, really nice exposure with the MacGyver for some like the follicular kind of like creeping around the corner tumors. So I don't ever turn him down. He's a lovely old retractor, but usually FKWO.
Interesting. Okay, I haven't tried that. So what does the group say? So this is a survey that we sent out. Some of you may have completed it, in which case, thank you very much. The survey was sent to members of the AHNS mucosal section and also to webinar registrants, and we had 102 responses as of Monday. And so we'll show these responses, and we'll also include a link if anybody wants to take it, if you didn't get a chance to yet, in the chat at the end. Oh, and one thing, please use the Q&A if you have questions or topics you'd like to discuss. So what type of intubation do you do for TORS? About half of the respondents always do nasal, which is what I do. 20% always oral, and about 25% do a mix. And then, oh, I'm sorry, 25, and the mix is nasal for tongue base and oral for tonsil. And then the retractor is probably based on what you have available, but for tongue-based, predominantly FK, and for tonsil, it was predominantly the Crow Davis, but there's a bit of a mix there for sure. All right, and in terms of which robot, it seems to be whatever's available. Interestingly, I was surprised to see that the majority of our respondents chose the XI or use the XI, 50%, and 44% use the SP, and very few use others. Okay, next, this will go to Dr. Kane. So again, it's the same patient, healthy, ideal TORS patient. Do you remove routinely the contralateral tonsil if it's normal appearing on exam and imaging?
So I don't. So the incidence of synchronous primary is so low. I think it's like 2.7%. And then additionally, the other thing that can happen when you remove the contralateral tonsil is that you're going to make their swallowing worse and their postoperative pain worse. So I don't think that the risk there, or the risks there are going to outweigh the benefits for those patients. So typically I won't.
So interestingly, I was for some reason under the impression that most people do remove the other tonsil, but most don't. About 70% said they do not routinely remove the contralateral tonsil. For I think similar reasons to what you stated. One question for I guess the panel is, have you seen a clinically relevant second primary kind of emerge after not removing the contralateral tonsil?
Yes.
Yeah, okay.
And it was actually a patient that I biopsied for someone else to do a case on, and so they ended up having to get treated on the other side afterwards. So we'd biopsied both sides, but not tonsillectomy both sides because they went to go do a TORS with a different.
Yep.
So
yeah, we wrote a paper on that from WashU, and I think Eric Moore wrote a paper from Mayo Clinic about second primaries in the tonsil tissue. And the interesting part is they're about 50-50 in the palatine and the lingual tonsil. So why do we pick on the palatine tonsil to take it out? It's probably because it's easy. I personally don't take out the other tonsil because our study and his study and NCDB study showed that the rates, about 2%. If you radiate those patients, it's even lower. So the second primary rate's highest in patients that have surgery alone, which makes sense. So the rate's so low, I personally don't remove it either.
Okay. Thank you. Okay, same patient. Dr. Jackson, how do you manage the margins intraoperatively, and what do you consider a negative margin?
I'll answer the second one first because I think it's the easiest. A negative margin to me is a negative margin. I don't think there's a distance. I think you either have a negative margin or you don't. There's some interpretation there from a clinical experience standpoint. The mucosal margins are obviously easier than the deep margins. So you have to use your judgment. If on your main specimen, 2/3 of the deep margin looks involved and you take a tiny little sample and it's negative, it's probably not negative, even though on paper it is. So I do think you have to use some judgment there. No data has showed that a 2 millimeter, 3 millimeter, 5 millimeter margin in the HPV positive population, it seems to make much of a difference. The other one is more philosophical because I know a lot of people get very heated about how you take margins, and people feel very strongly that they should be specimen based, or pathology should transect the tumor and determine it in the pathology lab. I think it makes more sense to be more thoughtful in that if you take out a tonsil cancer and it looks positive on the deep side or it looks positive on the anterior margin, I don't know why you would take that off of the specimen because you already know it's going to be positive. So in that case, I take it from the patient and clear it that way. And I often ink the true margin because in our institution, a negative margin is a negative margin. So if that ink's clean, it's clean. But if the margin looks clean on the tonsillectomy specimen, for example, I'm not going to go in and take extra tissue from the patient. So I'm going to take that one off of the specimen itself. So kind of a combination.
Okay. I think it probably also depends on your multidisciplinary team and obviously what they consider a negative margin. But our survey here showed that it was kind of an even split between 3 millimeters and 1 millimeters and no tumor on ink, with 1 millimeter being the most common considered a negative margin. And then in terms of where to take frozen ones or frozen sections, again, a kind of a mix between taking it from the specimen or from the wound bed or asking our pathologist to take the frozen section off of the specimen. And interestingly, there are some surgeons are not doing frozen sections, which I'm sure is a discussion with the pathologist. Okay, so similar patient, but now they have an unknown primary. So they have an N1 mobile little level 2 node, but it's considered a T0. So I don't think we have, oh, Dr. Lee's here.
Hi,
Dr.
sorry,
Lee.
just jumped on. Straight from the operating room.
I'll give you a break on this one. We'll come back to you for the next one.
Okay.
Back to Dr. Kegner. So do you use frozen section in your search for an unknown primary intraoperatively?
I do. So the typical I'll do is I will do ipsilateral tonsil send it for frozen. So the pathologist will usually bisect it in a couple of places, or quadrisect it, I guess. And then if that's negative, I go to the contralateral tonsil. And then if that's also negative, then I will do the lingual tonsillectomy as a permanent side. I usually will also look at the nasopharynx. That has been a place that we have caught a few times. And so I usually will put just an endoscope in the nose and sample the adenoid pad, or just, use like a Crow Davis and look back there. And that has actually been pretty successful for the most part in my hands doing it that way. And again, it does take a good relationship with the pathologist to make sure that they're kind of looking in the same spot that I am.
Yeah, definitely. It looks like most of us are using frozen section for unknown primary, about a third are not, and then 18% said sometimes. And I think that could be a whole lecture on itself, just going through the workup for an unknown primary. But this could be helpful in talking with your pathologist. I know we had to do some convincing that frozen section, could potentially help with this unknown primary workup. And so this could be good to bring up with your pathologist if that's a discussion. Okay, back to our T1 tonsil, T1 and 0 tonsil, but now this is their CAT scan here. So you can see the carotids right here. So retropharyngeal carotid. Dr. Lee, do you operate on patients with a tonsil primary with a retropharyngeal internal carotid, or two of them as it shows in the scan here? This is not my patient.
Yeah, you guys can hear me okay, right?
Yep.
Yeah, okay. So I don't think strictly the anatomical position in the retropharyngeal space is a contraindication. I think it depends a lot on where the actual primary is on the tonsil. I think more the way I actually even have a smart phrase in my Epic notes for this to remind myself to remember what's the relationship between the internal carotid and the tumor itself, the palatine tonsil tumor. So to me, that's more important, just the proximity of the two, than whether the carotid has a retropharyngeal course strictly, because it could be really far from the primary tumor.
Okay, so it's not a strict contraindication.
No.
Well, 25% of us agreed with you that they're willing to operate on it. Many surgeons said that they wouldn't, and this, some caveats that, if it's mobile for salvage or just a case-by-case basis. Okay. So we're going to go fast through these. So, okay, back to our same patient. And let's see, do I have an idea? Dr. Kane, which vessels do you ligate for tonsil, tongue base, and then for tongue base for unknown primary, so mucosectomy?
So typically I'll do facial and lingual for all of those situations. I think, for tongue base, if it's extending into the vallecula, I think you could also consider doing superior thyroid. And then for some people I know there are some people that will do ascending pharyngeal for tonsil, particularly if it's going onto the posterior pharyngeal wall. I don't typically do that. And there is actually a paper out there that shows that those patients are more likely to get first bite syndrome as well. So in general, I'm just doing the facial and the lingual.
Interesting. I wasn't familiar with that paper. That's good to know. Okay, so for our survey here, so it's a little hard to go through this, but facial and lingual are very common for tonsil or tongue base. Ascending pharyngeal more common for tonsil, and then superior thyroid sometimes for the tongue base. And then for the mucosectomy, most of the respondents, or the highest percentage, actually said no vessel ligation for the mucosectomy, which I think is supported by the OSA literature. So that brings us to our first expert consult from Dr. Lee, who will be discussing prevention and management of TORS bleeds, and he is going to share his screen, right?
I will share it. Yeah, can you guys see this okay? Okay, we'll zip through this. Obviously, it's a topic that can take many hours discussion and lots of different variations, I'm sure, amongst surgeons who do TORS frequently. But I'm going to share it in 4 slides. So for me, the principle, and this is learning over time, doing this for almost 10 years now, that one of the principles is that blood flow can flow through any of these arteries, the external carotid branches, in an antegrade or retrograde fashion. So just simply ligating the proximal end of the vessels that are in play is probably not enough. In most cases it is, and in some cases retrograde flow probably creates a significant risk for postoperative bleeding. So for me, my kind of standard approach for management of these vessels is thinking about where are the external carotid branches relative to where we're typically operating in the oropharynx. And the yellow kind of oval here is supposed to kind of mark out where, if you were to just head deeper in, through all that musculature into the pharynx, we're typically operating in the tongue base or the lateral oropharyngeal wall. So then that means the facial artery and the lingual artery are the primary vessels in play, maybe the ascending pharyngeal to some degree, and then hopefully the external carotid proper is not commonly in play. So for me, and I do this pretty standardly for almost every TORS cases, I actually pay a lot of attention to ligating as far distally along the facial artery as I can. So I ligate the facial artery over the submandibular gland just before it passes over the mandible. Obviously, you have to be careful of the marginal branch of the facial nerve. I actually ligate the submental artery because it's right there. And that takes care of a lot of the distal supply of the facial artery that could have retrograde flow. Then I ligate it proximally. Then I ligate the lingual artery as it passes under the mylohyoid muscle. And that's pretty standard across the board for most of my TORS cases. Maybe overkill for some, but it's what I do to sleep better at night, to be honest with you. This is a nice systematic review that probably everybody is familiar with. I think it came out in 2022, just looking at some of the studies, which were retrospective studies, looking at the value of transcervical ligation of various external carotid branches. There's a lot of variability about what branches are ligated, whether the external carotid is ligated itself. But the take-home messages from this, which I think were very useful, are we don't think that ligation of external carotid vessels branches there necessarily reduce the overall rate of bleeding, but the severity of the bleeding may be reduced because we're taking away a lot of the major blood supply to that area, or the major blood pressure to that area. So in all this noisiness here, the kind of take-home points are that preoperative antithrombotic therapy may increase the risk of postoperative bleeding. That's kind of intuitive. Preoperative radiation, perhaps from a prior primary, also could increase the risk of postoperative bleeding. That also has some intuition behind it because patients probably have poor wound healing, right? And then things like surgeon and volume, for the surgeon experience with TORS and the stage of the tumor maybe has some association with increased risk of postoperative bleeding after TORS. Now, with ligation of various external carotid vessels, including the external carotid proper, which was variable across all these studies, basically that didn't change the overall rate of bleeding. And that's what this meta-analysis and the data shows here. Nothing, all of these studies and the cumulative aggregate score of these studies cross one, which basically means the odds ratio is the same whether you ligate external carotid vessels or not in terms of postoperative TORS bleeds. However, there's some, if you look at these studies in aggregate, the risk of severe bleeding is lower in the group where at least some external carotid branches were ligated. Again, this is looking across all studies in a meta-analysis here. So that's also somewhat intuitive, right? And because we're almost always in the neck for a neck dissection, it makes sense to consider doing that. Okay? I'm just giving you one illustration of how I approach bleeding risk mitigation. And to me, the transoral efforts are what really matter the most. So this is a preoperative neck CT scan here for a patient who's had previous radiation and now has a right-sided tongue-based primary. So I'm gonna pause that there. The primary is right here, okay, right there. You can see lots of external carotid branches, and let me start up again. Start from the bottom here. Here's the bifurcation: internal carotid, external carotid, and then you can see a lot of branches near where the tumor is. Okay, and the reason I show you that, this is a preoperative neck CT or CT angiogram, and then intraoperatively we find what we expect to find if we're doing a good kind of resection with good margins. We find a branch of the lingual artery, which is predictable, again, based on the preoperative imaging. And I think it's really helpful over time to give myself feedback by looking at preoperative imaging after these surgeries to try to correlate that with what I see intraoperatively. And I think it's really important. I've learned over time, ligation of the distal end of any vessel that we identify. That was one. I'm kind of fast forwarding through this so I don't kill too much of our time here. Here's another branch of the lingual here. Again, I think my take-home message here is chase these vessels as far distally as you can, because that risk of retrograde bleeding, I think, is significant in these cases. Speed ahead here, because I'm probably pontificating for 10 minutes trying to figure out what to clip here. Okay, so that's done. And then there's one more. Okay. All right. And then I'm going to skip over that again for the sake of time and show you a post-operative CT angio. So this was unusual, but this patient had prior radiation, and she actually she spit up a couple clots of blood, not a lot of bleeding, but about almost 6 weeks after the surgery. Okay. So I got a CT angio just to make sure there was no pseudoaneurysm or anything that I really needed to address with neurointerventional radiology. And you can see all the clips along the surface, right? Clip toxicity, right? And no, I didn't see any exposed vessels or vessels right under the surface. And so I felt like this is just slow healing because of her prior radiation, and she did fine. Okay, but just as an illustration of thinking it through preoperatively, intraoperatively, and postoperatively. So things to think about if, God forbid, you do have bleeding after TORS, which typically happens somewhere in 7 to 14 days after the surgery. So I had a patient a few years ago who had a severe bleed. We got his airway secured, and we got him over to neurointerventional radiology. And they squirted some dye. This is actually a coronal view of an angiogram looking at the left side, internal maxillary artery. Can you guys see my mouse pointing up here? Hopefully, okay. And what's interesting about this is I've ligated the lingual artery in this patient. However, I don't think I did a good job of ligating it as far distally as I could reach. And so this patient actually has backfilling from their inferior alveolar branch of the IMAX all the way down to their lingual artery. And so as you can see, this kind of yellow oval, that's actually pointing to it. It's hard to see there, but on the sagittal view, you can kind of see it better. So you guys can see the teeth and kind of get oriented. Here's the internal carotid artery. This is the IMAX again. And there's this backfill all the way down to the lingual artery where I have ligated it proximally. So proximal ligation helps, right? But he still bled, and thankfully he was okay. But it's no joke. There's a lot of collateral blood supply and just this spider web of retrograde flow that you can see. And so they did a great job of squirting a lot of embolization coils into the IMAX, and he did fine. But again, I can't overemphasize what distal control means. And your best opportunity to get really good distal control of these vessels is when you're doing your transoral dissection. It's not the stuff that we do in the neck. And lastly, I would say that if you have confidence, and as we gain more confidence in vessel control transorally, we can be more confident in obtaining better surgical margins too, because there's less fear about going deeper, right? The more that we don't fear the things that lie beneath the surface. So I'll stop there and we can move on.
Thank you.
That's great, Ryan. Do you, in salvage cases, do you typically get a CT angiogram, or did it just happen in that case?
It just happened in that case. Yeah, I don't typically, just a neck CT with IV contrast, I think usually suffices, but just happen to have it.
Perfect. All right, so taking our T1 tonsil, now we have a patient who's on apixaban. So, Ryan, Dr. Lee mentioned, antithrombotic therapy as a risk factor for bleeding. So, Dr. Ketchner, do you offer TORS to patients who require anticoagulation?
I have a conversation with them. So, that with these patients, there's definitely an increased risk, and we know that outcomes with TORS can be comparable with radiation as a primary. So I usually have a pretty in-depth conversation with them regarding the potential risk for it. And it also depends on how much they can come off of it afterwards. Because for the antiplatelet things, that one I think has the higher potential for really catastrophic complications. So for patients who are really willing to go through with it, sometimes I'll even offer them a trach in some cases if it looks like it's going to be like a tongue base or a supraglottic, something like that. But it is something that I think on a case-by-case basis a lot of times.
Yeah, great. So when we asked everyone, it seems like, in general, there was, if they could hold it preoperatively, they're sort of willing to operate on patients with Plavix or Coumadin. And then for aspirin, about a third of you guys said that even if they could not hold it preoperatively, there's no problem, doing TORS with someone on aspirin. Dr. Keshan, would you operate on someone on aspirin?
Yeah, I have done. It takes a lot more care, and as Ryan mentioned, lots and lots of clips, because no one ever died of clip toxicity except for that one guy, right? But no, I'm kidding. But yeah, I mean, I think again, it's a patient by patient kind of discussion. A lot more care and kind of watchfulness as much as possible. But like for an 81 milligram aspirin, it doesn't make a lot of difference in these patients as long as all the vessels are controlled. So slightly higher risk of like the granulation tissue bleeding. And part of that we also mitigate with things like TXA rinses and, other topical hemostatics as well.
Great. So that sort of leads us to our next case. So now our tonsil patient has some OSA, and it's a tongue-based primary, Mallampati 2 on exam. And so, Dr. Kane, would you ever perform an elective tracheostomy for a TORS patient?
I would consider it. I mean, I think in this case, especially since it's a fairly small lateral tumor, I probably would not trach the patient. I would make sure that I would take them off of their CPAP for about a week. But in general, I don't often do elective tracheostomy, more commonly for patients that are getting like free flap reconstruction. And I do think, like Alex said, there's some consideration for discussing it with patients on anticoagulation and those with OSA, but I don't do that routinely.
Great. Yeah, it seems like overall on our survey, people agree with you about, a third never perform elective tracheostomies. And then the most common reason to perform a trach is for free flap reconstruction, and then OSA, and then as well as local regional reconstruction or patients requiring anticoagulation. And then if you look at some of the other patients, there's some concern for sort of salvage cases, and that might sort of go along with the free flap reconstruction as well. All right. So we talked a little bit about possibly sort of counteracting bleeding with topical treatment. And so, Dr. Jackson, do you ever use topical hemostatic agents intraoperatively or postoperatively?
Simple answer, no. Never. Never have, probably never will. My partners that have in the past, the ones that I see do it, I've used to do co-surgeries with a former partner as well. They would spray stuff in, and it was almost all swallowed by the end of the surgery. So, it's $500 worth of something the patient just swallowed. And I don't think there's any data to say that spraying like Surgicel or whatever, that Flow Seal, I guess Flow Seal is the stuff everybody uses, or that glue to seal. I don't think it makes any difference. It might make yourself feel better, but I don't know if there's any data at all to say that it prevents post-operative bleeding. I'm not talking about patients that are actively bleeding in the emergency room. I'm talking about in the operating room. I think just good control of hemostasis. Before the SP, I used the handheld bayonet bipolar in the oral pharynx all the time to control muscle and mucosal oozing. Now I just use the SP bipolar on the Maryland to control mucosal oozing. And as Dr. Lee mentioned, I control hemostasis of the vessels with clips.
Do any of the other panelists use intra-op hemostatic agents?
I don't.
No.
I just use
No.
TXA post-op like as a gargle, but not like in the operating room. I sometimes use a little bit of Surgiflow to make my heart feel better, but
Great. All right.
Yeah, I agree with Dr. Jackson. Oops, sorry, Michelle. I was just gonna say, because the kind of bleeding that we are worried about is the catastrophic bleeding, right? That comes from a rupture of a named vessel or big branch, and that's not going to be preventable with a topical hemostatic agent.
So it seems like on our survey, about a third of people don't use any topical hemostatic agents intraoperatively, but the rest use some combination of Flow Seal, Tissue, Surgicel, Arista. And then post-operatively is actually more rare, where only about 10% of you uses topical hemostatic agents post-operatively.
It's everyone who Dr. Kegner has told about the extraoral rinses.
we'll talk more about it in the pain section.
All right, so now going to our salvage setting. We have a patient now with a second primary, having had radiation about 7 years ago. And so, Dr. Lee, would you use any kind of local or regional flaps to reconstruct towards defects in this setting, or potentially free flaps?
That's a good question. I haven't done many of these, to be honest with you, in the post radiation setting. But for the ones that I haven't done anything differently than for a primary TORS case. Just let it heal up. But as in relation to that case I just talked about, it was 6 weeks after surgery where they were still healing and they had a little bit of bleeding. So it's definitely a prolonged healing course that they can experience after having had prior radiation. But I don't do anything differently.
Yeah, I don't have a lot of experience in the salvage setting, so it's interesting to see the survey results. So it seems like, about a little over a third of patients, survey participants use local or regional reconstruction, and it's a combination like submental buccal fat and fan flaps were the most common. And then in terms of free flaps, it's also a little bit less than a third, and primarily for sort of salvage defects, exposed vessels, or large soft palate defects.
Yeah,
Just
well,
to clarify, Michelle, this survey question was all comers, right? Not just salvage.
Correct.
yeah, I will say that for like salvage base of tongue, a lot of times that soft tissue I think does heal in pretty nicely, but for palate, pharynx, and kind of like that glossotonsillar sulcus, as Ryan mentioned, I think that the healing process takes a bit longer and it's harder for these patients to recover sometimes. And so they're often insensate there. So one of the things that I oftentimes will do, because I do see a lot of these actually, unfortunately, is a Gahano style technique where it kind of like excludes the part that can't feel and keeps the bolus in the sensate area of the throat. And I think it does help sometimes with some of the post-operative pain and getting vascularized tissue to that area.
Nice.
If they get radiated again, hopefully not, but.
That's awesome. All right, so that leads us to our next expert consultation with Dr. Jackson.
Thank you. You're going to control the slides for me, hopefully? I don't have
Yeah,
them.
I got them.
Perfect. Thank you. So full disclosure, I rarely do any reconstruction in my practice. My goal for TORS is to not do reconstruction. If I have to do reconstruction, I tend to shy away from TORS and tend to aim toward chemoradiation, especially when it comes to free tissue transfer and putting asensate tissue in there when they're now going to need adjuvant radiation therapy. But that's my bias. I don't know if I'm right. There are institutions now doing more transoral resection and then placing a forearm flap in the wound afterward. Here's a systematic review that shows people doing that. I'm not sure if it's right or not, especially in the primary setting. Despite all that, I've done a lot of different reconstructive techniques, and I'll talk about a few of those that I learned and a few that we tried to come up with on our own to help out with that. But those are mostly reserved for certain situations. The easy one is pharyngotomy repair. This happens all the time in my practice. I don't know if I'm just an aggressive surgeon or my residents are aggressive with Army Navies around the digastric muscle, but I tend to get a few holes into the pharynx. And I think that's okay. It's easy to repair. I usually just repair it with vicryl suture, suturing the submandibular gland back to the digastric or the digastric down to the soft tissue deep to it. You have to be careful there because of the hypoglossal nerve is adjacent. So be very careful in that situation. But there are other techniques too. And a former mentor of mine, or still a mentor of mine, Bruce Hoey, wrote a really nice paper called The Unplanned Intraoperative Pharyngotomy, the Plug, Pull, or Patch. And he would use a combination or in singularity, alloderm, tissule, and the submandibular gland digastric muscle is his plugs, his patches, and different things to seal those. And it makes a lot of sense. So I recommend people read that if they have time. I let those patients eat the same day. I don't find that a pharyngotomy increases their risk of fistula high enough. I've actually never had a fistula from a TORS patient. So I get a lot of pharyngotomies though, and I still let them eat that day, and they tend to do okay. We can go to the next slide. Sorry about that, Eleni. Carotid coverage is another one that needs reconstruction, and this is usually an oops, like in the operating room. Now you have either branch of the external or branch of the internal in the wound, or very, very dang close to the wound, and you want to cover that up. One flap that we're actually trying to publish right now with a couple other institutions, colleagues of mine at Emory with Mihir Patel, and at KU with Andres Burr, are putting together a series of submandibular gland flaps. And that's this patient you see right here, where we pedicled it on the facial pedicle and placed it into the wound, tacked it into place for either parotid coverage or palate reconstruction if they have a significant palate defect. And they tend to heal pretty well with low morbidity. Again, I'm not doing that every day or every month, or hopefully not even every year. This is one of those things where I get caught off guard intraoperatively and need something to fill that hole when the patient's not consented for anything more significant, or they don't need something more significant. The longus capitis muscle is a nice, thick tube of muscle that you can use. And Bruce Hoey and Jason Rich at WashU first described this as a laterally based flap to cover the carotid. And I'll show in the next page, we use it to reconstruct the palate as well, but that'll get you out of a bind too, because you can tack it to the pterygoid sling as a laterally based flap, and it stays pretty viable and it heals very similar to this photo as well. And then you have other regional flaps like the submental island flap, which is a very good flap if you know how to do it and you haven't already burned those vessels to do it. And then obviously radial forearm free flap is our workhorse for forearms. I don't do that very often. It tends to be in the patient that can't get definitive chemoradiation. Say they have poor kidney function, or they just refuse chemo, and now they have a survival advantage to have surgery with radiation over radiation alone, and they need palate reconstruction or carotid coverage. We can go to the next slide. And then, the palate and larger pharyngotomy defect, I think, is where bigger reconstruction comes into play. Buccal fat, I don't do it. I'm terrible at it, I think, because I've never seen it do anything. When I see them afterward, they got all this necrotic fat in there. Maybe I'm too aggressive or not aggressive enough. I'm not sure, but I would talk to somebody who knows how to do it better and has better success. But I have not found it to be as valuable. Some people do FAM flaps, which are reasonable if it's a small palate defect. You can do a pharyngoplasty and close the palate down to the constrictor muscle that's left. I have not found that to be very valuable in the long term, in my experience. It's very valuable a day or two after surgery, and then when I see them back 2 weeks later, it's open, unless I put something over top of it. And that's where me and my partner, Patrick Pipcorn, came up with the longus capitis muscle. Instead of laterally basing it for carotid coverage, superiorly basing it and flipping it up into the wound. And you can see that at the bottom picture. The bottom two pictures is the intra-op and post-op photo showing that muscle laying over top of the pharyngoplasty repair. And I have not had any of those patients break down, but we are writing a follow-up paper on that, because we did have a case of cervical spine osteomyelitis afterward. Just as a word of caution, to be careful if that patient's going to get radiated after, that they have a higher risk of toxicity from this flap around the bone. Submandibular gland flap, again, showed a picture of that before, plugging that hole. Bruce Hoey originally described it to fill the pharyngotomy, but it works well for the palate also. And obviously the submental flap and your forearm flap, as we discussed earlier. In the, I should mention, that's in the primary setting. We talked about the salvage setting right before my slides popped up. And I think that's a topic that's going to go on for a while, and we're going to have arguments back and forth in a healthy way. I don't know the answer if we should put a free flap in every salvage case. Those that argue for it, their arguments make a lot of sense, that it's going to take a week or two longer to heal. You're going to have more granulation, higher risk of bleeding longer term. I get that. I still tend to reconstruct in the salvage setting as if it was the primary setting. If they need reconstruction, I do it. If they don't need reconstruction, I don't. I don't know if that's the right answer though. I don't know if we're ever going to know if that's the right answer. It's going to take a lot of patience. And like Ryan Lee said, we just don't do enough of these as a community until we pull all of our data together to really know 100%. And thank you.
Thanks, Ryan.
For sure. Yeah, I haven't seen the submandibular flaps. That's great. So, moving on to swallowing. I think we're at, I don't know if Ryan, let's go back to Dr. Keshner. I don't know if Dr. Lee stepped out. Do you place a nasogastric feeding tube intraoperatively?
I do, because it's a pain in the neck to have to do it later, and I like to know that it's in the right spot. So at the end of the case, I usually will do a quick DL to make sure there's no bleeding when everything's kind of collapsed down. So I just quick pass the tube and I bridle it in, and then if they don't eat it the next day, you can take it out. But it's much easier and much more comfortable for everyone involved to do it at that time. So I've never not regretted that. Wait. I've never regretted it. How about you? Yeah, I've never regretted it.
Yeah. Among our survey participants, about 43% said, only as needed postoperatively, and about 35% do it prophylactically for all patients, similar to you. And then in sort of the prophylactic for certain patients, it sort of depends on whether they have flap reconstruction, sort of larger cases, salvage cases, and then more base of tongue versus tonsil in older patients. And then if we take our T1 tonsil patient, we had a TORS and ipsilateral sort of neck dissection. Dr. Kane, when would you start an oral diet, and when do you typically involve speech language pathologists in their care?
So I'll start the patients on clears immediately post-op. We typically get our speech language pathologists involved preoperatively, and I'll talk a little bit about that actually in my slides. And then post-op day 1, the patients will be seen for a clinical swallowing assessment by the speech therapist prior to discharge. And typically they're available also for swallowing assessments in the post-operative period as well during clinic follow-ups.
That's similar to our practice here. So it looks like about 41% of people start immediately post-operatively, and the rest sort of either post-op day 1 or post-operatively after SLP evaluates them. And then again, the majority of people have involved speech language pathologists prior to surgery, and the rest are sort of routinely post-operatively in the hospital. All right, so our next expert consult is Dr. Kane talking about TORS swallowing optimization.
All right, so thank you so much again for having me. My speech therapist thought it was really funny that I was doing the swallowing part, because if I could, I would probably have one of them attached to my hip at all times in clinic. This is a great topic for me. So as all of y'all know, swallowing function after TORS is a significant quality of life metric. Hutchinson et al. Published a systematic review in 2015 looking at predictors of post-TORS swallowing function. What they found was that there was significant predictors of swallowing function included baseline function, which makes a lot of sense. If the patients have baseline dysphagia, they're more likely to have dysphagia after TORS as well. Patient's T stage and nodal status, base of tongue primary tumor. Also patients that get adjuvant chemoradiation. They also found that end stage independently predicted persistently poor long-term swallow related quality of life per MDADI score. So I think these are all things that are important to take into consideration when you're evaluating a patient for treatment recommendations for surgical versus non-surgical management. We can go to the next slide. I'm not going to spend a ton of time on this slide, but what I wanted to demonstrate here was the wide range of different metrics that are reported in the literature in order to assess TORS swallowing function after surgery. You can see here there's a number of different quality of life metrics or validated swallowing assessments that have been utilized in the literature. However, their instrumental swallowing assessments are not widely reported on within the TORS literature, and that's going to include fees as well as modified barium swallow. So I think it's important just to recognize that there are a number of different validated swallowing assessments and quality of life metrics that are out there. So when you're interpreting this data, just kind of know exactly what you're looking at. All right. moving on to the subject of perioperative feeding tube use. So use of either NG or G-tube placement varies really widely. NG-tube placement reported in the literature varies anywhere from 3 to 100%, G-tube placement up to 39%. And typically this is going to be based on institutional protocols and varying opinions on whether prophylactic placement of feeding tube in the perioperative period is necessary. There are some obvious drawbacks to feeding tube placement. As we all know, G-tubes are not without complication as well as morbidity afterwards. NG tubes can also cause patients discomfort, and there's also a need for education for use for both the patient and their family members. This does add to the burden of care and the postoperative recovery, particularly for patients that do have limited resources and potentially limitations in healthcare literacy as well. There have been a couple of larger retrospective studies that have been done recently. These are single institution studies, both published around 2021. So the Plonowska study looked at about 95 patients, and they found that their NG-tube placement rate in the perioperative period was 23.2%. They found that predictors of NG-tube placement were going to be large tumor size and patients that underwent bilateral neck dissection. Fang et al. Published a study on a cohort of about 140 patients. Their feeding tube placement rate was even lower, so it was only 3.6% feeding tube placement in the perioperative period. And there was a significant association of feeding tube placement with posterior pharyngeal wall location, which I think makes a lot of sense. That's just going to be more painful for the patients postoperatively. You're going to discourage them from swallowing. And also HPV negative tumors. Also, this is pretty intuitive because you're going to be taking wider margins compared to HPV positive disease. They attributed their low rates of feeding tube placement due to close collaboration with speech language pathology, which I think is really valid, and I've seen that as well in my practice. So typically at the University of Mississippi, just to kind of share what we do and what our experience has been, is all the TORS patients get a pre-op clinical speech assessment as well as pre-op education. In general, this doesn't really include a clinical swallow evaluation unless it's indicated based on patient symptoms, at which time they'll definitely do a clinical swallow. And then in salvage patients, we have a lower threshold to do a modified barium or a FEES if they have baseline dysphagia. I think it's really important to emphasize the point of preoperative education. I think that with the patients, when we prepare the patients more for what to expect in the postoperative period, I do think that it makes a difference in the patients that are going to be more likely to need a feeding tube placement versus those that are going to understand that, you know, their pain is going to get acutely worse. They're going to have a couple of days of pretty severe pain where they may not be able to do solid foods, and they're going to need to kind of push through in that period of time. We typically educate the patients on having appropriate nutritional options available post-op, including things like protein shakes like Boost and Sure, which I think helps as well just to prevent weight loss. And then I think the other thing with it that I'll mention is I think that hearing the similar subject in a different way, I think is helpful just to prepare the patients for what to expect post-operatively. And I think that they gain a lot from hearing it a second time from the speech therapist. As I said, I typically start patients on clears immediately after surgery. They all get a clinical swallow evaluation prior to discharge. And then the speech language pathologists are typically available for assessments in the postoperative visits as well. We do clinical swallow evals really kind of on a case-by-case basis, as well as FEES. I'm going to say that probably happens a little bit more in the salvage setting, and that's probably more for larynx, salvage larynx, than it is for oropharynx in my practice, has been my experience. So main takeaways, I think it is important to have speech involvement early and often. I think there's a lot of benefits to education as well as patient support. There is a wide variation of measures of both subjective and objective swallowing evaluations utilized in the literature. And I think that prophylactic feeding tubes do not seem to be necessary in most cases. I think the literature demonstrates that. And in general, in my practice, I don't place prophylactic feeding tubes unless there's somebody that has been identified preoperatively that we have concerns is going to have problems in the postoperative period. And then also just the importance of patient education, what to expect in that postoperative period in terms of their swallowing. Thank you.
Thanks, Anne.
Yeah, patient education, sort of getting the patients on board is so important, especially in these TORS patients. So now we're sort of going to our pain management topic. And so Dr. Jackson, what do you typically use for pain control?
So I stole this handout from Jeremy Richmond many years ago, and it has saved my nurse her sanity. And basically, it's a calendar that goes day 1 through 14, and it has little check boxes for Tylenol and what time they take it, and ibuprofen and what time they take it, and oxycodone and what time they take it. And ever since we've been giving this out, I wish I studied a pre and post, because the phone calls that she gets has been drastically reduced, because I think patients really overestimate how much Tylenol and ibuprofen they take. They would call and say, "Oh, I took a Tylenol yesterday and I'm in so much pain today, I'm dying." I was like, "Well, shoot, you didn't take any Tylenol." Like, "Well, I took one yesterday." It's like, "You took one yesterday. That's not enough." So I give Tylenol and ibuprofen around the clock. I don't think ibuprofen's a problem. Our pediatric colleagues have been giving ibuprofen to tonsillectomy patients since the black box warning of Tylenol with codeine. How many years ago was that? I was a resident. So, 15 years we've been giving ibuprofen around the clock for tonsillectomies, and it has not been shown to increase the bleeding risk to any degree. So Tylenol and ibuprofen is the main player. They get oxycodone as breakthrough pain. And my nurse knows that when they call 3-4 days after surgery, that tends to be when their pain is at its peak. I don't know what happens on that day, 3, 4, 5, but something happens with inflammation maybe, and their pain worsens. If they call, she'll give them a Medrol dose pack, and that tends to get them over that little hump. And it also lets me be a surgeon and not an endocrinologist, because I don't like managing diabetes. I don't want to manage diabetes. So I used to give steroids liquid to them to go home with, and I just got tired of dealing with it. So now if they call 3, 4, 5 days after surgery, they get a Medrol dose pack, and it takes that edge off and gets them through the rest of their course. So pretty simple, nothing fancy. I don't do gabapentin. We did a prospective trial, randomized, blinded control trial, and it showed no difference in pain control with gabapentin. So basically Tylenol, ibuprofen, some oxycodone for breakthrough, and maybe a Medrol dose pack.
Do you do any oral rinses?
No.
Okay, and so when we look at our survey participants, I think everyone agrees with the Tylenol and steroids. There's a large proportion of gabapentin patients, people who prescribe gabapentin. And then also a third of people also do a topical anesthetics, probably similar to lidocaine. And then narcotics are on the lower side. And then there's a group of people who do Celebrex as well as Toradol. And then surprisingly, oral NSAIDs are actually quite low, which is probably due to people's pre-existing biases regarding NSAIDs in TORS patients. So it's great to hear about your practice. All right, Dr. Keshner, would love to hear about how you optimize pain management.
Yes, me. I am the pain person. So you can go to the next page. So how do you measure pain? And hopefully that puts the Rent song in your head. But anyway, there are so many different ways that we can measure pain. There's a great review. We can go to the next slide. Dr. Vusala Snyder, a little shout out to our MUSC AFPRS fellow, currently was part of this publication, looking at all the different ways that you can measure pain. Really the most common one is our visual analog scale, the happy face to sad face kind of thing. But we also use MDADDY scores, we use quality of life scores, but what that tells you, there's so many ways to skin a cat that we don't have really the best way. So when there are lots of ways, it means there is no good way. But we try to. And so there are many ways to look at it. So next slide. One of the things that we actually just talked about, like what are some of the ways that we can mitigate pain that don't necessarily involve opioids for addressing this postoperative pain. So great paper by Dr. Van Abel, who is, I think, joining us here virtually. And so they actually looked at the gabapentin question that Dr. Jackson brought up and saw that, scheduled low dose gabapentin was really not associated with pain control or increased respiratory depression, and also that ibuprofen was fine. So, a lot of the things that we kind of heard about a little bit ago. Next slide. Interestingly enough, though, so if you actually look at the mechanism of action for gabapentin and pregabalin, you actually have to start it about 1 to 2 weeks ahead of time. So you're really not going to get the benefit of the actual medication unless they start it ahead. And so usually it's a ramping up from, 300 milligrams daily to up to 3 times a day with a maximum dose of almost 5,000 milligrams per day, starting with the first dose at nighttime. Again, at least 1 week to notice any difference, and in some cases up to a month. So, by starting them the day after surgery, we're not really doing a whole lot, even though it's a standard in a lot of places. And when you're discontinuing it, you also have to give a taper over 7 days, which I think a lot of us don't. It used to be an epilepsy medicine. So you can imagine there are all sorts of fun little side effects that can come as people come off of that medication. It's excreted renally, so that is something you have to take into consideration. And then gabapentin really is only absorbed in the small intestine, whereas pregabalin is absorbed along the entire intestinal tract. So the pregabalin tends to have a better, quicker onset. However, there's also a potential for addiction, which again is something that we want to avoid in these patients because we want them to go back to their lives and doing their thing that they do. But something to take into consideration. So I wouldn't say goodbye gabapentin completely without really utilizing it the way that it was meant to be used. Next slide. So one of the things that I think a lot of us have been trying to work towards, and I think that the American College of Surgeons has done a really great job pushing ERAS protocols, not ERAS tour like Taylor Swift. But this is to kind of get people educated ahead of time to know how they're feeling, what they're going to be going through, to have their nutrition consultations, things like that. And so Dr. Ganti and all of his colleagues through Rush University actually looked at utilizing the ERAS protocol with pre-admission education, nutrition consultation with speech and language pathology, as Dr. Kane mentioned, doing the pre-op carb drink, doing the gabapentin preoperatively, and then all of the kind of the things that we had just talked about. If you click the next one, and it showed that actually the outcomes were statistically significant. So it's the prehab oftentimes that actually does a lot of the work for us, which can be hard to do, especially if you have a busy clinic. But by kind of institutionalizing it or mechanizing it can really help, because we can't ever tell someone how they're going to feel, right? You can't tell someone what pain they're going to have. But one of the things that we can do is at least prepare them with like, hey, here's some things that you might feel. And so that really does improve outcomes and things like that. Sorry, my computer buzzed back. Okay, next slide. So again, another awesome study, Dr. Castellanos and Swanson looked at using these opioid-sparing multimodal analgesia type of protocols. And again, the too long didn't read version is lowered opioid usage in the ERAS group. Multimodal pain regimen seems to work well. So that's the main takeaway from this. Next slide. So what about glucocorticoids? So we're talking about, I don't want to be a diabetes doctor. I don't think any of us do. I don't know how many insulins you're supposed to give when you have diabetes, but there is some data, and Dr. Lee actually is featured on this paper looking at a randomized controlled trial utilizing corticosteroids for pain after transoral robotic surgery. So in this case, they actually were using IVs, and I tend to be more towards Ryan's, Dr. Jackson's mindset. I do like a nice Medrol dose pack for home. I do think that it does help that sort of that hump as they get towards the end of that first week of surgery. I usually will give like 3 doses in the hospital for tongue swelling and things like that. But I do think it does help significantly with pain. And they actually found that this was the case in their randomized controlled trial. Next slide. Other ones. So this is going back to the 90s when a lot of our fellow surgeons were born, which is a little bit insane now. But this is actually looking at some of the topicals. And, one of the things that we talk about resource restricted areas and things that patients can do at home. So sucralfate is, Carafate is another trade name for it. So this is actually a medication that can coat the tonsillar bed. So for patients that have undergone tonsillectomy, even if it's just for benign purposes, there was a study in 1992 that showed that pain, otalgia, trismus, milliliters of pain medication percent of diet eaten, percent of strength return, all improved with the use of sucralfate. It's a cheap medication. It's easily taken. There are no real toxicities with it. Can also help a little bit with reflux. So not a terrible thing to have. And then a comparative comparative randomized interventional trial is essentially so the same thing, that it did improve our pain scores. So let's get weird. So, some of our patients can't take opioids, or they have something wrong with their liver, or they can't take whatever medication and they want to do something different. So interestingly enough, there are a bunch of ketamine clinics that are opening up probably in a city near you. But microdosing a little gargle with ketamine actually has been shown to improve post-tonsillectomy pain. This is actually a really nice adjunct if you've got a patient who's tried all of the things and they're still just calling in incessantly, say, I don't feel good, everything feels terrible. And it's one that it does have to be compounded, and you have to find a pharmacy that's willing to do that. But it can help significantly with sort of that lingering pain that patients may have. It's actually interesting. I did not include in one of the proposals too, is for patients who do have the first bite syndrome, that this might also be something that can help with those patients. So, I just tell patients not to swallow it per se, just in case. It is a very small dose, but it never hurts to give them the fair warning that they might have some really groovy dreams. But also, if they have to go through radiation, this is another nice adjunct to give them if they do start developing radiation mucositis. Next slide. So what are the take-home points? Take-home point is we want the patients to go home and feel comfortable if we can. So consider prescribing the gabapentin or pregabalin at the pre-op visit to begin about 1 to 2 weeks prior to surgery. That'll help the patients kind of get their bodies ready for everything, helps them prepare in their mind as well. The ERS protocols for multimodal analgesia pre and post-op, and I think that's something that we all as a society should push to do. I think it will help quite a bit. Corticosteroids may help shorten time to PO and may shorten length of stay. And then topicals can impact pain, time to PO, and need for additional opioids. So your lidocaine, your TXA, sucralfate, and ketamine. Oh, and I forgot about the TXA. So TXA actually considered typically for tranexamic acid, typically considered for stopping bleeding. However, if you look at traditional Chinese medicine, it's actually been used for throat pain as well as inflammation. And there are some small studies in just standard post-tonsillectomy patients that it does decrease pain and decrease time to PO intake. So next slide. So thank you for your attention. Laughter is the best medicine, followed closely by dexamethasone. So, honestly, I think there are so many ways to skin a cat, so we can try all the different ones, but ERS protocols.
Great. Well, thank you all so much. We are running just a little bit over, but hopefully that was helpful for everyone here. It's given me a lot to think about and go home and research some more. So thank you all to the panelists and to the AHNS for organizing.
Great job, Eleni.
Mm-hmm.